The heart sits in the center. Okay, so let's break this down. Here's a typical sweep through the stomach. You see correct situs and the heart. We're going to sweep from the 4-chamber LVOT. Look at that. See 4-chamber. Oh, it's a short clip. It's only 12 seconds. But here you can see 4-chamber, LVOT, RVOT, and then your 3-vessel trachea view. I have more clips coming up so you can see the thymus gland and so forth. So let's take a look here. Okay, so before we look at those other clips, let's go over a few settings that's routinely used for the heart settings. This is just only for your heart views, okay? So of course we want to zoom in on that image, which you can see here. You want to decrease your sector width and keep your angle at a less than 30 degrees, okay? If you're sampling, you want your sample gate to be at 2 millimeters, okay? Pay attention to the angle and the scale with your color Doppler to avoid artifact. Okay, increase your dynamic range. Your focal zone, try to use just one and have it right at the heart or directly below it. And then lower your scale when necessary. Okay, and I'm going to show you some reasons to why you would need to lower your scale. Let's move on. So here it is in a setting where you can see your pictures. You see the difference that it makes with these views, starting with the high frequency probe. Okay, so you see high frequency probe creates that depth, as well as the appropriate color gain, your PRF settings at a high setting, especially when you're looking at the AV valves and the narrow color box. That's how you can really see the regurgitation. And then in your grayscale, you want to make sure your harmonics, your compound frequency, and your speckle reduction settings are on, okay, just to create this nice, crisp picture. Okay. All right. So before we look into the heart, we have to be familiar with the proper positions. Okay, this is important, especially if you notice something abnormal, so you can give the correct results to your radiologist. So with level position, which is normal, that's going to be heart position to the left. Meso position is in the center, in the middle, and dextro position is to the right. Now, what makes that different from the cardias is that the apex is what's directed to the position, not the position of the heart, okay? So level cardia, the apex is directed to the left side. Mesocardia, the apex is directed to the midline. The heart is still positioned normally. And then dextrocardia, the apex is positioned to the right. Okay, so that's the difference. How I remember that is that because the A's are at the end, that tells me apex. That's how I remember the difference between that as well as the positions. Okay, so let's look at an example of a particular one. Okay, so here we have a fetus is positioned in head maternal right. We'll make sure we're all still there. Everyone's still there? Okay, just making sure. Okay, so transverse head maternal right. How should our positions be placed? Remember, we learned that our stomach should be positioned at 3, and then the heart apex in the transverse head maternal right should be where? It should be at 5 o'clock. But in this particular example, the heart apex is at 7. So this told me that this is dextrocardia. Okay, heart apex is to the right. Okay, I just want to check, make sure we're still good, that I didn't receive any notifications. I think we're still good. Okay, yeah, so it looks like we're still good. Okay, so heart apex is to the right, so this is an example of dextrocardia. Okay, all right, so let's look at sweep. So this is a lovely sweep. It's in color, and you can see that it's showing the 4-chamber view, We're able to see the 3-vessel trachea view because we see the V. Let's watch it again. And then we're able to see the thymus gland, and it's bordered by the mammary arteries there. So this is a perfect, it's 12 seconds where you're able to rule out quite a few of your heart anomalies. Let's take a look at just a grayscale sweep. You're looking at the exact same 4-chamber LVOT, RVOT, as well as the image of your thymus gland, which you can see here in the center. We can watch that one more time. There's the thymus gland, LVOT, 4-chamber, LVOT, RVOT, and then your 3-vessel trachea view. Okay. All right, so for our accreditation, these are all the standard views that are required for us to obtain for our level 2 scans. I'm going to show you examples of some of my pictures, just starting with the 4-chamber view, which you can see here. You can see the pulmonary veins there enter into the left atrium. Here's a standard RVOT view. You can see the bifurcation of the left pulmonary artery and the right pulmonary artery. Aortic arch. You have the ductal arch. Here's another LVOT. And then here is a typical situs where you can see stomach, aorta, IVC. Okay. I do have some in a color. Okay. So once again, LVOT, we have to show both in grayscale and color. So you have the color of the LVOT as well as the RVOT showing the bifurcation. We also show short axis, which you can see here in the chief, as well as the 3-vessel trachea view. Okay. All right. Now this is what we were talking about earlier about lowering our color scales so we can see particular structures. It's very important to lower the color scales and settings for your pulmonary veins, as well as picking up the ARSA anomaly. The ARSA anomaly is the almost #1 most common aortic arch anomaly. And so in order to see this extra vessel heading towards the right fetus right shoulder, you have to have your settings at a lower color scale, usually below 20. Here in my example, you can see it's at 18 in order to achieve this extra vessel. Okay. All right, here's an example of aortic arch as well as IVC, SVC. Very important to image the IVC, connect it all the way through so you can rule out interruption of the IVC. Same for your aortic arch. Okay, we also include ductus venosus. Ductus venosus is included for all of our standard 20-week scans. Very important structure to see. And in some settings, when it's not there, usually there is a different connection, usually if that happens. But we routinely see the ductus venosus for all of our 20-week scans. Okay, and you can see where it connects with the umbilical vein towards the IVC. So it's just right here. Okay. All right, so now we're getting back to some of our standard measurements. So starting with the AC measurement, notice, do you notice right away from our AC measurements, it's the same landmarks from our situs view. You can see your aorta, your IVC, here's your umbilical vein, the portal vein, as well as the stomach. So these are the landmarks that you'll see to get a proper AC measurement. Okay, if you see a portion of the kidney or bladder, you're off axis. Okay, so you want to only have these landmarks in your AC measurement. Okay, now we're getting to the spine. Now, coronally, that's not a view that we typically do routinely unless we're looking at the renal arteries. Usually we just standard do the sagittal and transverse views of the spine. Those are the standard views. Okay. And it's important to sweep all the way through in cases of these anomalies here. I've seen where all 3 of these anomalies were missed because we did not image all the way through, especially towards the sacral. So it's really important to sweep all the way through the spine in both sagittal and longitudinal. Right? And we're getting down to the end. So with our extremities, you want to image both bones there, especially in the forearm, as well as your humerus bone. Same for the leg. You want to see both bones there, tib, fib, and your femurs. Now, for some labs, the humerus bone measurement is not required, which, every lab has different protocols, but standardly, we do measure the femur length. Okay, that's required for our measurements. Okay, and why is that important? Here are some, just a few, because there's many, but just a few of your hand anomalies that are routinely seen. You want to be familiar with the terminology, okay, the proper terminology. So in a case where there's more than normal amount of digits, it's called polydactyly, okay? In a case where there's fusion of the digits, which you see here, that is known as syndactyly. And clinodactyly is when you have the curvature, which you can see here, of the fifth digit. And this is usually seen in the T21 Down syndrome cases. So these are some finger anomalies that are present. Okay. Here are some foot anomalies. Okay. I broke it down so you can see the association that it has with particular chromosome issues. So your sandal gap toe is usually associated with T21. Rocker bottom is usually associated with T18 and T13. So you can see a rocker bottom foot. And then your club feet is usually associated with the T18. Right? And cord, very important. Please, please, when you're imaging your cord insertion into the abdomen, please make sure to show the connection of the umbilical cord and to see the umbilical arteries, to not confuse the iliacs as umbilical arteries. I've seen it done, and I've seen where we did include, or we did document that there was a through vessel cord when indeed it was a two vessel cord. So it's very important to show the connection, just like that. In cases where there is a two vessel cord, which you can see here, you want to document which vessel is present or absent. In the case where there is an absent right, usually that is presented with multiple birth defects. Very strong association, okay? And all you do, you just see what side the stomach's on and so forth. That's how you determine your left from right in order to be able to determine which vessel is present. Very important. All right, so we're getting down to the end. So now we're at the placenta and the cord insertions. So you want to document whether it's velamentous, normal, or marginal, okay? Eccentric is what I've read on the eccentric insertion is basically if it's not in the center, but not marginal. So that's known as an eccentric insertion. But typically, the views or the terms we use is either if it's velamentous, normal, or marginal cord insertion. Now, my examples that I have here is of a marginal cord insertion, and marginal cord insertion is when the cord inserts within 2 centimeters towards the edge, okay? And that's known as a marginal placenta cord insertion. Now, in cases when there is velamentous insertion, you have to definitely rule out if there's a vasa previa present, okay? And vasa previa is when the cord is presenting rather than a fetal part, which you can see in this case, the head is down, but the cord is presenting in relation towards the cervix. Very, very dangerous. So this is something that you want to pick up prior to the patient delivering. Very important pickup. Okay. All right, so this is just a review. We should probably all know these standard placenta previas, starting with the complete. I find that marginal and low-lying are often confused. So marginal is when the edge of the placenta directly touches the internal os. There is no space in between. There's nothing to measure. The edge is right at the os. Where the low-lying presentation is where there is some room to measure from the placenta edge to the internal os. Now, usually if it's within the 2 centimeter mark, I guess you can say 1.9 mark, then it's considered low lying. If it's past 2, then it's all clear. Okay. So let's look at examples of that. We're going to talk about cervix examples, and I want to show, I have the example of a previa at the end that I want to discuss with you. But before we get there, I want to talk about proper cervical measurements, okay? So typically, we standardly do our cervical measurements transvaginally, and it's due to just cases like this, for example, where you see that the bladder is full, and look how long this cervix is, 7.4. It's making the bladder is creating an overfill. The overfill bladder is creating the cervix to be very elongated, which is not real measurements here. It's not true measurements. So you want in this setting to either have the patient empty her bladder or do a transvaginal exam. The transvaginal exam is the better approach when measuring this cervix, and I'll show you why. So look at this example. Okay, so there's 3 separate measurements here. The first measurement is the transabdominal approach. Now, mind you, all 3 of these measurements are from the same patient. Okay, all 3. So look at the transabdominal approach. They're getting a cervical measurement at 1.62. You see that? That's very short. Now look at the translabial approach. They now have it at 1.8. It's still short, okay? And here is in C, this is the transvaginal approach. And you see the difference? It's at 3.4. You see? So indeed, the cervix is normal, it's long, and it's appropriate. That's why transvaginally is the standard approach. It's more diagnostic, it's more accurate, which we see in this example. All right, I think we all should know how to perform. So just in case, if we don't know, I can just go over the steps briefly. So definitely you want the patient to empty her bladder. You do not want to do it with a full bladder. You want to, of course, clean your probe, do the proper covering of the probe, insert inside, and you're going to do a measurement from the internal os to the external os, which they show here in A and B, okay? Do 3 measurements. I always do at least 3 just to get a different comparison and get more accuracy. And then you want to apply pressure and see if there's any changes with pressure, as well as after pressure, because sometimes you can see where there's a delay response in the opening of dilation of the cervix. And so you want to wait a minute at least after pressure to see if there's any changes with the cervix. Okay. All right. And then let's take a look here. So here are some examples of, you see, cervical incompetence. It's pretty bad. This one looks pretty bad, especially this one here, with only just a little bit of the cervix there. And so in cases where you see the fundulin, the proper way to measure the cervix, do not include the funnel portion as your cervical length. You only include the closed part. The closed part is considered the true cervical length, and then you do a separate funnel length, okay? That's the proper way as far as documentation in cases where you see that there is an incompetent cervix. Okay. All right. So you see here, these are different techniques with your transvaginal probe. sliding, rotating, sweeping, and rocking. Do not hesitate to do this to achieve all the views and measurements that you need, especially in cases of previa, your placenta previas, as well as if the cervix is incompetent. Now, I want to show you why in this last example here. So you see, oh, yes, nice long cervix, head is down. I used one of the techniques, and then voila, you see that there is a partial previa present. By the way, patient was refusing to do a transvaginal exam, but upon I coached her into doing it, and sure enough, I'm glad we did, because I did not see that there was a partial previa transabdominally. And so I did reiterate the importance of the transvaginal approach in cases of this. Notice my bladder is full, or her bladder was slightly full, but it was just a little slightly full. It did not interfere with my measurements here. Okay. All right. And I believe that was all. Just lastly, before, because this is the last slide here, I wanted to end with my systematic approach with my level 2s, okay? So I usually group these segments all together. So if I'm looking at the head, and depending on the position, these are the views and measurements that I am achieving, as well as the face, which you saw in my sweep, okay? So that's one segment. And then you have your abdominal segment, as well as your heart, okay? Then your measurements is another segment, okay? Then your extremities, followed by spine. And then lastly, I always save my placenta and cervix views for the end. You don't have to follow necessarily this order, but creating this systematic approach, I find that I'm finished with my exams following this approach faster. If you take a look, if you give each segment 5 minutes per se, that's less than 30 minutes here, okay? It's right at 30 minutes. Now you're going to probably spend more time with your heart views and maybe your head views, but you won't spend that much time with the placenta and cervix. So that's going to give, some of that time from there, as well as your biometry measurements. Your extremities shouldn't take you more than 5 minutes, maybe 2 minutes at the most. So yes, it is achievable. Just think about this systematic approach. You can achieve these views within the time frame. Hopefully, with these tips, I'm hoping, you have to tell me, give me some feedback if that's the case, but I'm hoping that you're able to achieve these views within 30 to 45 minutes. Okay. All right. I'm all done, but I just wanted to point out that I have some OBGYN questions coming soon to prep Pride to join my echo questions, probably sometime later on in the year. And then also, this is the link to my YouTube channel. It's under Ultra Pro Cert if you want to find me. Right now, it's just a few echo lessons, but I do plan to put some OB and GYN lessons there shortly. All right. I am all done. Hello.
Hello.
Hey, Nat. Hey. Hopefully I
It,
didn't go over.
it was a very
I was
well
trying
timed
to stay within my time frame.
That was a very good presentation. Thank you.
Thank you. Thank you.
Uh, I was about to give you a chance to introduce your YouTube channel, but you already
Mm-hmm.
mentioned it. Just to give some quick testimony,
Mm-hmm.
after I watched your YouTube channel, I even
Mm-hmm.
named the clock method as Lasher's method. It really made it easy for me. So it really made it easy for me to have a brief concept about the fetal cycles. So thank you for that.
Mm-hmm.
And it was a
Mm-hmm.
very interesting and well-timed presentation, and we all appreciate your commitment and uh,
Sure.
this very wonderful presentation. So I'm gonna give a